enzyme that destroys various classes of antibiotics, and that lets another bacteria grow that would have been destroyed by that enzyme. So these lead to necrotizing infection, and they also allow low densities of organisms to cause invasive infections. And I know you know all this, but just to reiterate, the infection occurs at this level in the subcutaneous fascia. Very rapidly, host responses and bacterial toxins cut off blood flow. And I don't know if you can see this, but this is a patient with a colon emergency colectomy, was treated just for 24 hours, despite having peritonitis from the perforation, and developed this necrotizing infection, very wide debridement, and he did not survive this incident. So, starting antibiotic therapy for patients who are serious, critically ill with septic shock, they should be administered as quickly as possible. For example, if a patient comes to the emergency room with what appears to be septic shock, we start antibiotics actually in the emergency room, usually within 1 hour. And then the other point I want to emphasize is that if you start treatment before the operation or procedure you're going to do, you should redose the patient just before you make the skin incision. And very commonly, we did a survey at our hospital, and very commonly, for example, appendicitis patients would get a dose of antibiotics in the emergency room. 8 hours later, they'd go to the operating room and they'd have a perforated appendix, and they wouldn't be treated with antibiotics. So it's very important to know the time that antibiotics were given and then redose them just prior to the operation. And the other point I want to make is that most of the real benefit of antibiotic treatment comes in the perioperative period. So if you operate on a patient and don't use active, appropriate antibiotics and wait a day or two to begin, that greatly increases the failure rate. In fact, those patients will not improve even given the benefits of the operation. So we really think and believe very strongly with very good data that antibiotics should be given preoperatively and continued on empirically until you know what you're treating. So the real problem that we're dealing with now, and I think globally, is the rise of what are called beta-lactamases. Now there are 3 classes of them, and if you'll notice, this has stopped in 2009. Over the last 4 years, this has increased even more greatly. And there's almost every bacteria we see, but particularly common bacteria like E. coli and Klebsiella, have a class of antibiotics that destroy most of the beta-lactams, meaning ampicillin and ceftriaxone, cefotaxime. And then we've seen a rapid growth over the last 5 years of particularly this group that destroys drugs like ceftazidime and even cefepime and piperacillin. And the only drugs left then to use empirically, if you're in an area of very high prevalence of these bacteria, would be either carbapenems or colistin or aminoglycoside. So this is looking at these ESBLs by region, and the highest region is the Asia-Pacific region. And I point out this is old data, that it's now up to over 50%. Latin America is similarly very high, particularly for bacteria, for infections that started in the hospital. And then finally, this is for South America. And I regret to say that Mexico has a very high incidence of these organisms. Again, this is from 2009, and I haven't seen more recent data on this, but I'm sure it's been published. But this rate now for ESBLs really changes what you do for empiric treatment before the patient, before you really may have, if you're fortunate, microbiology. And the problem with these ESBL bacteria, which you see here, is they're primarily susceptible only to carbapenems, including meropenem, doripenem, imipenem, and ertapenem. They're also susceptible, at least in the laboratory, to piptazo. It's not clear how clinically active that combination is. And generally, we use carbapenems for these, and then amikacin is very effective. So these are our recommendations for what to do for high severity. These are from guidelines we published with the Infectious Disease Society of America and the Surgical Infection Society of North America, where we use carbapenems as our best first choice of organisms. I would point out that this guideline was written for the U.S., where we have a much lesser problem with ESBLs. So when should you treat for ESBLs or for Pseudomonas, which has several mechanisms of being resistant? So the first point is not in simple problems of perforated appendicitis or cholecystitis. The trigger for treatment then really is more severe types of infection. So what I would call high inoculum infections, which are bowel perforations, colon infection, colon perforations, and peritonitis, and post-operative infections that get a hospital-acquired group of ESBL-positive organisms. And then the other point I want to make is that we're all comfortable saying, well, if a patient is immunocompromised, then they should be getting very aggressive antibiotic treatment. But the point is that patients who are in sepsis, who have a severe systemic inflammatory response syndrome, are immunocompromised. That syndrome is really causes white blood cells not to function very well, and it really leaves these patients very much as if they were receiving immunosuppressive therapy with steroids. So this has been very well studied, and I think it's a good reason to use very aggressive antibiotic treatment for these patients. So I want to finish this lecture by discussing a whole different area where most of the more serious infections that we treat now in our hospital, particularly if they're post-operative infections or infected pancreatitis, are not operated on. There was a very nice lecture yesterday on the management of these kinds of infected patients. And basically, we see a fair number of them and have gone to very much not operating on them acutely. And this is a patient, as you can see here, with air bubbles in a necrotic pancreas. And this is necrotizing infected pancreatitis. And what we do with these patients is to initially percutaneously drain them. And I'll show you in a minute how we do this, because we use extremely large drains, and then they go through, they're connected in a circle so that we can change them very easily, and so that if they become clogged with the material, the solid material in the pancreas, we can clear them out in place or exchange them at the bedside. But basically, these procedures will cure about half the patients. And then in those patients who are not cured, it delays the operation until they are physiologically much better. The difference between who can be treated successfully really is how much liquid there is at the site of in the pancreatic bed. if I can show you this, this is not, doesn't show the liquids very well, and most of this, and what you see here, is actually liquid. And then this is the patient after these fairly large drains have been put in, and you can see a lot of the liquid has been taken away, leaving this remnant. And I think a lot of people are now moving towards treating these with initial percutaneous drainage, re-CTing them at 1 week, and determining if there's a, determining if this remnant is here, consider a laparoscopic or retroperitoneal, not transperitoneal approach to removing much of this type of material. And in our hands, it's been very successful. In fact, I think that we rely too much on percutaneous drainage in cases where patients are getting better very slowly and have on their CT scan a lot of this type of material here. So this just goes to hospital-acquired infections. And again, I think when we deal with seriously ill patients that would likely go to intensive care, and who have colon perforations or other severe diffuse peritonitis, or with post-operative infections that occur like from an anastomotic leak, etc., that those patients all be treated the same, and that is in an area where there's a large number, high percentage of these ESBLs, you'd be concerned about that. I think the most important issue in any case is how well you perform source control. And I think percutaneous drainage has taken away the urgency of operating on patients. And I think operating on these kinds of critically ill patients really makes their survival less likely. So I'll just, this is just to restate what I said, and I want to thank you very much. Thank the Society for the great pleasure of being here. And thank you for listening to this lecture.